Well, thank you for keeping your camera active during the seminar. So first, I would like to remind you to communicate with us through your McGill email, not your personal email. It makes it much easier to have all the information in one place that it's related to your program. Now, I have some announcements regarding the progress tracking. Some students, they update after they finish the RAC meeting, they update my progress, but they don't inform us. So if you don't let us know, we have no idea what you uploaded on your progress, so we can't operate in your file. So please, as soon as you updated your progress, let us know what you put there, so to be able to update your file. If you have a strong academic record, CGPA over 3.5, and you're interested in pursuing a PhD, please let us know. You can fast track, and we have a small award of $2,000 for the students who are eligible to fast track for this academic year. Now, we have students who are gonna presenting, starting with this seminar. Thank you, Pega. Thank you, Moskan, for organizing all that. As you know, last year we had some awards for the students. So for the best presentation was $200 for the first one, the second $175 and $150 for the third place. And we also have the amazing seminar question. Now, if you're interested to do a summer internship, it will be open, the registration for March. Send us your CV. And if you are selected, you will receive permission to register. It's a limited number of places, 6, so send us your CV. And of course, the last one, do not forget to send your abstract for the research day and to register. Thank you.
So thank you very much, Laura. And it is my pleasure to introduce Dr. Trafford Crump, who is an associate professor in the Department of Surgery here at McGill. He's also an associate member at the Gerard Bronfman Department of Oncology. Professor Crump is the Jarislowsky Foundation Chair in Thoracic Surgery at McGill University's Faculty of Medicine and Health Sciences. As a health services researcher specializing in surgery and surgical oncology, his work focuses on enhancing patient-centered care and maximizing the value of surgical interventions. His research program is dedicated to developing and implementing personalized metrics to improve surgical decision-making and patient outcomes. Throughout his work, Dr. Crump has gained expertise in the collection, analysis, and interpretation of patient-reported outcomes, including treatment preferences, experiences, and clinical results. He trained at the Center for Health Services and Policy Research at the University of British Columbia and earned his PhD in Evaluative Clinical Sciences from Dartmouth College. And the title of his talk is Advancing Surgical Oncology Through Personalized Metrics. So please feel free to put your questions in the chat, and at the end you can ask questions. After Professor Crump's talk, we have Nadia, who is a student, and so you can reserve the questions at the end, but feel free to put all your questions, those who want to put in the chat. As you can see, it's got a value, a dollar value. We also give you a nice certificate, which you can use for your CV. And thank you, Professor Crump. Crump, it's all yours.
Great, thanks everyone. Yeah, just to start, I don't have anything to disclose. And today's talk, we're going to be focusing on 3 things. One, what is this concept of patient-reported outcomes, and how do we measure them through patient-reported outcome measures? And then I also want to turn our attention to how do we select the appropriate patient-reported outcome and the respective measures? And given that this is a graduate level program, the focus is going to be really on how we use these in research studies, and not necessarily clinical practice or healthcare policy. While there is some overlap there, those are quite different strategies. So, and would have involved a much larger talk, maybe even a full course. So we're just going to narrow the focus on doing this for the purpose of research. And then I want to highlight some of the challenges associated with patient-reported outcomes data, some of their limitations, and where the future of this work may take us. Okay. So let's get started with the introduction and background. There are a variety of conceptual frameworks that can be used for defining what we mean by patient-reported outcomes. And some of you may be familiar with these. They essentially outline the fundamental aspects or factors that we want to consider when measuring health. And as you can imagine, health is a very nebulous concept in and of itself, and there's a lot of debate over what should be included or excluded. So grounding your work in a clear conceptual framework is very important. I myself like this model by Wilson and Cleary, and we'll get into it in a few slides. Okay, before we go too much further, I think it's also important to specify the perspective that we're taking. I mean, as we know, there's the surgery itself, but the surgery is actually just one part of a much larger episode of care, which includes things like prehab or and post-op. It also includes the wait time for surgery. Certainly in Canada, we're all familiar with wait times. And then on the other end, rehabilitation from the surgery. Also, as we referred to here, recovery and ERAS at McGill. And then we can stretch it even further if we want into this and include wait one, which is a concept of the time that one waits from being referred by their general practitioner to the surgeon. That can be a very lengthy wait in which patients are living with the symptoms associated with their desire for surgery. Of course, we can come at this from a patient's perspective, and quite rightly in patient-reported outcomes, that's exactly what we do. But we can also expand it to look at things, other groups like family and informal and formal caregivers. I guess also formal caregivers. Sorry, I didn't know that was coming. The healthcare system. So looking at it from a health systems perspective on how we're doing addressing patient-reported outcomes, and then even at the policy level. So we can include it, as I mentioned. We can include the concept of patient-reported outcomes from a policy perspective. Okay, so let's define what we mean by patient-reported outcomes. And the first question I always ask is what's the best way to find out about a patient's status? And the answer is quite simply to that is, well, you ask them, right? It's kind of the no-brainer. And while that's appropriate in clinical care and certainly necessary, it's not really efficient or effective to do that as part of your research study. You can't very well go around and ask every person in your research study how they feel, because they'll all have very different ideas about what their health is comprised of and what it includes or excludes. Obviously, it can be very slow. Patients may not get to the point, or may tell elaborate stories as part of their explaining how they feel. It's hard to tease out from basic conversations what is the priority or the burden that's having the greatest impact on one's quality of life. And then it's not systematic, it's error prone. It's all these different issues associated with asking somebody how they feel. So we've come up with this concept of patient-reported outcomes, and really, I mean, this dates back to really the beginning of medicine, in a Greek philosophical sense, but in more modern times, it's certainly in the early 60s and 70s, there was recognition that patients' perspectives are important in medical research. And then in the 80s and 90s, we developed this idea of patient-reported outcome measures, which we'll get to in a few slides, to more formalize the collection of PROs. And then more recently, we've started to integrate these into clinical trials. And that's why this definition here is, which is the most common definition you'll find, is taken from the FDA, because they included as part of the regulatory framework for approving new drugs and interventions. So why might somebody be interested in including PROs in their research? Well, you may simply want to know about the patient's perspective on symptoms, on their symptoms and function. You may want to go beyond what could be measured as part of clinical measures or performance-based measures, and these may not be observable to a care provider or a third party, an external party. And then finally, we can use patient-reported outcomes for economic analyses. So something we won't be getting into very much today is that the patient-reported outcomes can be translated into what are called utility values, and those utility values can be used in cost-utility analyses, which are used as part of a quality measure. So here's that Wilson and Cleary model that I mentioned, and this is one that I think is some seminal work that came out of the mid-90s. As I mentioned, when patient-reported outcomes are really starting to become more formalized in research, and when we were starting to develop more of these conceptual frameworks for what exactly we meant and what was included and what was excluded. And you can see here, starting over at the, I guess, my left-hand side, we have these biological and physiological variables, which we may measure through clinometrics or performance-based metrics as part of a standard clinical workup. But those influence symptom status, functional status, how we get on with our day-to-day activities, and then which cumulatively influence how we perceive our general health. And then, of course, that goes on to have a strong influence on our overall quality of life. And then on either side of that flow chart, you can see sort of these internal and external characteristics that further influence these factors. So things like one's social network or social support system, their financial situation, their own personal motivation and intrinsic values that go on to influence. And just if you stop to think about this for a second, you realize just how difficult it is to measure a patient-reported outcome, because all of these different influences are more or less variable, by individual, and it's very hard to control for that, even with the metrics that we have. So here's an example of how we've put that, or how that framework has been put into action in an advanced cancer setting, where you have the clinometrics over on the left, and then the symptom status measures how Rodriguez and all are measuring or operationalizing the functional status, and then the general pop and quality of life, and then how they're operationally defining the characteristics of the individual and of the social environment. And so it's really important that this is really key, that we take our conceptual framework that we're using, whether it's a Wilson-Cleary or some other one, and then we properly or very clearly define how we're going to measure those concepts. So what are the operational definitions that we're going to use in order to quantify those for our research study? And that takes us to prompts when we're talking about quantifying, these concepts, which are essentially, structured, hopefully in most cases, validated questionnaires that are standardized and that we give to patients to fill out, and with which they report their patient-reported outcome. Now, if you think back to the definition from the FDA, where we weren't intending to, or patient-reported outcomes are not meant to be interpreted through anyone else. That is, they're meant to be direct from the patient. You start to see maybe a conflict here with a survey instrument that some researcher in an ivory tower has created, being used by patients to report their health status. So, I think this is an area of debate, whether or not a PROM really gets us to a pro, at least in the ideal world. But it is what we've got right now, so that's what we're using. Now, there are a number of different types of PROMs, and they tend to fall into two main buckets: the condition-specific and the general health. The condition-specific are meant to measure a specific condition or organ type, or can be used to measure a disease, and they're more applicable to specific patient populations. That is, to those patients that are suffering from the condition or have issues or symptoms related to that organ type. And they're far more clinically relevant and sensitive to changes in those symptoms or functionalities. Now, many of these have been poorly developed and have not gone through rigorous psychometric testing. You also can't use these to compare different patient populations. So if you were interested in comparing, the patient-reported outcomes of someone who's gone through a hip replacement with somebody who's gone through a cataract replacement or cataract surgery, you wouldn't be able to do that using condition-specific instruments. Instead, you might opt to use a general health prong, because these simply measure one's overall health. They're generic measures meant to be applicable to anyone. And many of these have gone through robust psychometric testing and research and are quite well validated in the research. The problem, however, is that in trying to be generic, they're not very specific to changes, or they're not very sensitive to changes in specific symptoms or functionality. And there are many to choose from, and you can't necessarily compare one to the other. So if you choose to use the EQ5D, you can't compare the patient-reported outcomes generated from that with the SF12 or the Huey or any of the others that have been developed. So you're kind of locked in depending on that. And then within each bucket, we can further define these into symptom status, functional status, preference-based, which are really those that generate the utility that I mentioned earlier, and then health status indices. And I don't want to get too much into this other than to highlight the fact that those different buckets relate very well to our conceptual model, or at least the Wilson-Cleary model that we discussed earlier, which is one of the reasons why I like it so much. Now, you can have a range of study designs using patient-reported outcome. You can simply follow somebody across time and observe how their symptoms or their patient-reported outcomes change. You can look pre-post an intervention and see what the change in patient-reported outcomes are. And in some cases, we're like in emergency or trauma surgery, we may only be able to collect patient-reported outcomes after the surgery. I want to emphasize this because I think it's very important, and sometimes it gets confused. Patient-reported outcomes are not experience or satisfaction surveys. They do not measure patient preferences for risk, time, or treatments, nor do they measure patient goals, values, or expectations. Those are all different concepts, all different measures that have different conceptual frameworks. As looking back on the Wilson-Cleary, we didn't see any concept there that included patient satisfaction. And patient preferences require different techniques, different elicitation techniques, often necessitating trade-offs, such as in a standard gamble or time trade-off technique or threshold technique. And we don't get that in a patient-reported outcome measure. And nor do we necessarily, while we can use patient-reported outcomes as the basis for exploring one's goals or values, they're really just one part of a larger communication process involved in say, more shared decision-making or more patient-centered kind of delivery of care. They're just one aspect. They, in and of themselves, are not patient-centered care or shared decision-making. Okay, so I mentioned that there are a number of different proms to choose from. And again, I just want to emphasize that those that you choose for a research study might be very different from the ones that you choose for clinical practice, because they're intended to serve two different purposes. For research, you're looking at either controlling for a population or measuring an outcome. For clinical practice, you may just be simply trying to standardize the elicitation of specific symptoms. Now, there are a bunch of different frameworks out there. I like the Cosman framework on how to select a prom. I don't want to get too into the weeds here on the framework. I mean, bottom line is just try to avoid developing one of your own. Like it is the last box for a reason, because you do not want to have to go through that. It's painful process. And so to quickly go through, to quickly reflect on that flow chart there, the Cosman framework, you want to look at, again, one that aligns. You want to look for an instrument or a prom that aligns with your conceptual framework. So that's really important. You want to look at what else has been used in previous research studies, because this is going to improve comparability and should a systematic review or meta-analysis be done in the future, it's certainly going to facilitate that. You want to make sure that a patient-reported outcome has been developed and validated for your population or treatment of interest. And this is important because, in the last, let's call it 5-10 years, treatments for, certainly in the surgical oncology world, have dramatically changed. And yet we're still using proms that date back to, the late 90s, early 2000s, when these treatments weren't in place, and these instruments haven't been validated for these treatments. And I caution on this one, perhaps it's not one instrument, but a few instruments that you can combine to reach your measurement goals. And we'll get into why I caution on that in a minute. Some logistical considerations are, some of these have been developed and require licensing fees, or may be restricted for use depending on your intent. Some of them can be used in multiple different modes of administration, but others are probably inappropriate for that, or difficult to achieve. Say if you're trying to move from a paper-based to a web-based collection mode. The time is always a factor, and then the responder burden. So responder burden is as somebody's asked more and more survey questions, they're less and less likely to fill them out. I'm sure we've all been roped into filling out some kind of telephone survey or web-based survey, and you're wondering, like, how much longer can this go on before you just click out of it or hang up. And there's no differences when you're asking a patient to fill these out. Okay, some research considerations. Yeah, so because this is research, you will have to ask patients to fill out an informed consent. And prior to coming to McGill, I was at the University of Calgary, and we were forced to use this informed consent template that was like 28 pages long. Often in case it would take you longer to go through the informed consent form than it would be to ask a patient to fill out the prom itself. Standardizing time points for collecting proms can be really challenging, particularly if you're collecting this in a real world setting as opposed to, say, a trial. And certainly in surgical oncology, trying to standardize a clinical pathway with all the different adjuvant treatments, both pre and or post, surgery, is really problematic. They all have different success rate. The different modes of administration have different success rates, and you have to adjust your sample size. And then you have to be aware that the way that you're collecting data is ultimately going to there's going to be some inherent biases in those. So just be wary of those. And then, some further logistical considerations, right? The time, consent plus responding, and patients actually thinking it through can lead to delayed clinics. And the reason I put that in there is because often in a real world setting, we're asking patients to fill this out while they're in the waiting room. And, there can be stress involved in that, both on the patient side and on the clinician's side. And it can be, very challenging, and certainly something you want to weigh. If you're collecting it by paper, you want to think through your data entry process. Who's going to be doing that? If you have research staff, that's great, but it's going to take up some of their time, and you're always going to have data quality issues, whether they're mistyped or inverted numbers or those kind of things. So you want to have a data quality plan, a quality assurance plan in place, whereby you're checking data that's been inputted periodically. And then having to store these hard copies takes up a lot of space. Digital considerations. I'm sure we've all seen apps, and your mileage with these can vary. They have, how you access raw data, if you can, is a big consideration, and what the quality of those data are. We used an app called Ocean a few years back for a study, and it exported, while it allowed you to export the data, it only allowed, it was labeled data, so it wasn't numeric, which made which made the analysis, that much more time consuming. And not everyone has an email or mobile phone, and I know it's hard to believe this in 2025, but the Division of Thoracic Surgery, for example, collects or cares for patients in Gatineau, and very few of them have an email or mobile phone number associated with their patient chart, which means if we were to roll out a digital way of collecting pros from them, we would be very limited in the sample that we collected. And then I think there's still some people who are like, don't want to enter their health information online. So you're going to need a data entry plan and making sure that you're scoring the pros correctly. It's every patient-reported outcome measure has a different scoring guide or their own way of scoring. And some of them are very straightforward, very easy. Others are far more difficult and confusing. The more formal proms have scoring guides and on a website that you can download, and it's very, very easy, very straightforward. Others, you got to go back to the original manuscript in which they were published and then figure out how the scoring is done. And undoubtedly, you're going to have some missing data, whether those are skipped questions or people who circle between two different numbers on a scale. I'm between a 2 and a 3, and you need to know if you're going to drop those observations entirely or you're going to impute for missing data. And then here's just a classic example of a very complicated scoring manual. This is for the EPIC 26, which is a very popular prom in the world of prostate cancer. And you can tell, on the one hand, it's great that they got a scoring guide, but you see here, first of all, you get a bunch of questions that have different response values or different scales that get standardized into a value, some of which run from 0 to 100, others range from 100 to 0. And then down here, then you've got to determine if you want to get into the domains, those are different questions that you've got to factor in. And then you have to account for the allowable missing data. So, once you've finished your PhD in math, and you might be able to figure this out. Certainly, you're not going to be doing this on the fly if you're trying to like score somebody, after they filled it out in the weight room and are trying to get in, to see the doctor. This is not something you're doing on the back of the envelope real quick. So that's that. Your data analysis plan is also you're going to have to determine how you're going to use the pro, if you're going to use it as the outcome of interest, or as I mentioned, to just control for health status. And then are you going to use if you're doing a longitudinal study, are you going to use the first pro? Are you going to use the second pro or the one that comes later? Or are you going to look at the change in the score? Because that may be something that you're more interested. And then having a plan for the loss to follow up is also something that you'll inevitably be asked, because that can influence or bias your results depending on the study and the population. And then it's really important here to understand that statistically significant differences across groups may not be what you're looking for. You may be more interested in what are known as minimal clinically important difference, or MCIDs, which is the small amount of change that is needed to be meaningful to a patient. Because we know we can p-hack our statistical significance by increasing our sample size or seeing big differences, but those may not necessarily reflect a true change experienced by a patient. All right, so in summary, I hope you're taking away that pros are used to measure, or pros are measures of one's symptom, functional, and general health. And we use PROMs to collect both generic and condition-specific perceptions of those. You want to make sure that you factor in your research and logistical considerations when selecting a pro and the accompanying PROM. And also when you're putting together your study design, you want to think about how you're collecting these and plan ahead accordingly. And that's all she wrote.
So thank you very much, Professor Crump, for wonderful and enlightening presentation. I think we'll since there are a number of questions, I think we'll go to the questions before we go to Naja. So we have a couple of questions in the chat. Question by Fatima: how do differences in language and culture affect the accuracy of PROs?
Yeah, this is a great question, and this is one of the limitations of patient-reported outcomes. Is that many of them have not gone through cultural adaptation and translation, and as I'm sure many of the audience knows, that entails more than just simply translating an English version of a survey into a different language, particularly when we're talking about different cultural and social constructs that may influence the intent of the survey or of the questions being asked, and may influence or color the way people respond to those. So some of the more formal prompts, and I work in the cancer world, so I'm thinking of like the specific cancer ones like EORTC or the FACT. They have formal guidelines for how you go through a cross-cultural validation study. But and certainly the smaller or less formal condition-specific ones don't have those. So the onus falls on the researcher to do that before they try to use the prom in a different language or in a different culture. I hope I answered the question there.
Yes, thank you.
So the next question comes from Muskan Alad. Could precision outcomes replace traditional PROs entirely, or can be used as complementary tools?
Yeah, so I think the precision outcomes are still new, and it depends on what you mean by exactly what you mean by precision outcomes. I think patient-reported outcomes comes from a world where handing somebody a survey, a paper-based survey guide was really the most realistic way of collecting the information from a patient. And I don't know in 2025 if that's still the case. Some like in the States, they have a system called PROMIS, which uses computer adaptive testing, or a CAT system. They have, rather than having a static instrument, they have an item bank. And like if you've ever taken the SATs or an exam like that, how you respond to the first item determines which item comes up as second. So there's been a little evolution there, but I think in this era of AI and machine learning, you'll see the collection of these outcomes go even further and get more personalized. And I think we'll move away from standardized instruments to somehow being able to quantify, to quickly evaluate and quantify discussions one has with say an AI bot, something to that effect. Keep in mind, the best way to ask, or the best way to get a patient's perception of their health is to ask them. So can we translate that into an effective way, or can we use that effectively in research? Maybe sort of the new frontier.
Thank you. Yes, I understood. Thank you.
Thanks, Muskan. Mohan, we'd like to hear your voice.
All right. So thank you so much, Dr. Crump, for the amazing presentation. My question is more or less falls into the pragmatism point of view. So the thing is, like, say if the pre-existing scales don't match to whatever objective I'm trying to put out there, is it a good idea to maybe make a completely new scale, or maybe supplement an already existing one? Because one of the issues that I face is that to ask patients to fill in a lot of questionnaires. So what do you think? What do you think I can do in this case?
Yeah, as I mentioned in the talk, the last thing you want to do is try to develop your own. because I mean that in and of itself is a multi-step study process, involving multiple studies. And so it's incredibly time consuming, labor intensive, and may ultimately get you away from what you want, what you're trying to accomplish. I think if there isn't one out there that meets your needs, you may try combining a couple or a few different prompts. For example, if you're interested, I don't know what you're interested in, but you may look at combining a short general health questionnaire with a depression questionnaire and a pain questionnaire, or you may look at seeing what is closely related. If there's a problem that's been closely related to the group that you're interested in, can you extend that and validate it in your to the patient population of interest? So I would encourage you to explore those options first before jumping into the idea of you're going to develop your own. In terms of modifying a prompt, it's really it's not advisable to do that, right? The prompts have been validated as is, and anytime you start even tinkering with the language in which the questions are asked or the scales in which the responses are scored, you get into a whole bunch of trouble, because now the validation doesn't necessarily apply to the instrument that you've modified. So I would certainly not do that.
Okay. Thank you so much, Professor.
Yeah. So next question by Temitop Joshua. Temitop, did you want to ask it?
Yeah, sure. So great presentation. Thank you for the presentation, Dr. Crump. So my question is on how can healthcare providers be effectively trained to implement shared decision-making using the patient decision aid, that is the tools out there, and integrate the prompts into the clinical practice?
Yeah, I mean, that's a little outside the scope of the talk, which was focused on research, but I'm happy to answer it. I mean, the shared decision making, every physician every healthcare provider is going to have their own style of how they want to incorporate these tools, whether they're prompts, decision aids, or anything else into their practice, and how they want to use those to facilitate shared decision making. To give an example, I used to work in the division of urology, and they would prescribe a shared decision making, or sorry, a patient decision aid to patients, like they would say a drug. And essentially it was a username and password that granted the patient access to a library of videos and sort of questionnaires, and then provided a report to the physician on where the patient was having issues. And so that was one approach. And then a different urologist had a very short questionnaire. I think it was 8 questions. And he was only interested in 3, the responses to 3, because he had his own heuristics of, these three items were indicative to him of how the patient was doing, and what sort of clinical treatment they may need adjusting. So it's really personal. and I don't think a prescribed approach or a top-down approach is effective, because everyone is going to have their own way of wanting to do things. So I'm sorry, I'm kind of punting on that question.
That's okay. Thank you.
Yeah.
Yeah. Thank you, Temitope, for that wonderful question. So, Muskan, you want to ask?
Thank you for your presentation. It was really great, and it is something new to know. Like, it's something new for me to know. So my question is, does focusing on the precision side of the outcome increase the complexity of research study? Because the questionnaires are mostly like patient tailored to a specific field rather than generalized question, which
I think that there certainly can be some complexity. There can be some complexity because of the different factors or the different concepts that get measured. And you may find in some cases, for example, physical health is improving, but mental health is deteriorating. And then you're left as a researcher on, how do you interpret that? And so, yes, it can get more complex depending on how you want to analyze and interpret your results. I think the other aspect is that many of these patient-reported outcome measures are not linked to any sort of clinical guidelines, or at least very few of them are. Some of the more rigorous, some of the more robust condition-specific ones I have, like in pain and depression, you'll find more. Some of them are more likely to be linked to specific actions that you as a clinician can take, or you as a researcher can interpret needing. But those are more the exception than the rule. And so the other complexity that comes in is, okay, so you have these results, like, what do you do, right? Like, what do they mean? And this is where I think that there's a disconnect between the patient-reported outcome measure and actual action, or how you're supposed to change relative to the responses that you're receiving. And we didn't get into it, but everyone, the other aspect is, should you be striving? Is it realistic to think that every patient is going to be at perfect health, or what is the goal that you are trying to achieve with in the patient-reported outcome that you're measuring? And that's going to be unique to an individual patient, but it may be aggregated up to say a sample or a patient population of, what is realistic what is the ceiling here that is realistic to achieve through more healthcare. So these are some of the things that you as a researcher will be forced to think through as you're trying to report your results and interpret them, and then and suggest sort of how they influence the field and in what direction.
Thank you. Thank you so much for answering.
Thanks. So you mentioned that prompts used in research, that they differ from those used clinically. I was just thinking that wouldn't there be some sort of distinctions and challenges, especially when you're going to translate these findings using prompts into clinical practice? Because there seems to be a gap there. How do you bridge that gap?
Yeah, I think that's one of the major limitations of PROMs and why you haven't seen it, despite having we're now like almost 30, we're over 30 years into, the sort of some of the original PROMs that were developed back in the early and mid 90s. We haven't seen them gain a great foothold either in clinical practice or in health system evaluations, or even at the health policy level. And I think part of that problem is exactly this gap that you've identified. How do we take the results, because a research study is obviously going to be reporting aggregate results, changes in the average patient, and the immediate interpretation from a clinician's perspective is, well, every patient is going to be different, and I can't use these results to necessarily guide, how I treat an individual patient. So the adoption of PROMs at a clinical level have a different range of considerations and implications. And while research may help sort of, I think, direct or show where we stand on the aggregate, it doesn't very well influence how we should treat patients individually. For example, like I mentioned, the importance of the MCID, the minimal clinically important difference. Every patient will have their own minimal clinically important difference, and you as a clinician have to figure out what that is. Yeah, it's challenging, and I think a big limitation of trying to use these in practice.
Yeah. Thank you very much for that really exciting presentation. I still had a burning feeling as I was hearing from Mohan and from Fatima. I can see the impetus where one would like to create their own PROMs, because you can see it. But I like the way you said, don't even think about it.
Yeah, please. If I leave you with anything, do not do your own.
Because I can see some social bias, like Fatima expressed, Mohan, I can see some sort of cultural bias in the PROM that you want to fix, etc. And then those are carried forward. So, yes, no, thank you very much.
Great. All right, guys.
And thank you, everyone. So we're going to go to Naja. Pega, it's all yours.
Thank you, Dr. Wally. Hi, everyone. Welcome to the first student presentation of our fall winter seminar series. I said fall, sorry. We are excited to hear from our talented students. Our next student speaker is Naja Ben Mohammed. Naja is a board-certified gynecologist from Switzerland with a strong research interest in surgical education and simulation. She began her postgraduate training with a one-year fellowship in surgical simulation at McGill University's Department of General Surgery in June 2022. She then pursued a one-year clinical fellowship in minimally invasive gynecologic surgery at University of Montreal before starting her master's in surgical and interventional sciences, focusing on surgical education in fall 2024 under the supervision of Dr. Jason Harley. Following her master, she plans to complete another year of minimally invasive surgery training at the University of Montreal before returning home in the summer of 2026. Today, Naja will be presenting transference of skills in the minimally invasive surgical modalities. And before we begin, please note that you will see an evaluation on your screen. We kindly ask you to complete it to provide valuable feedback to our speaker. Also, feel free to use the chat or unmute yourself to ask your question at the end of her presentation. Please join me in welcoming Najia. Najia, the floor is yours.
Hi everyone, Pega, thank you very much for the introduction. I am just going to share my screen. Let me know if you see my presentation.
Yes, we can see. Thank you.
Thank you. Okay, hi everyone. So as was already said, I'm a staff gynecologist at the University Hospital in Geneva. And my topic has been surgical education and simulation for some time now. And back home, I do teach and supervise residents during their laparoscopic simulation workshop. So it's naturally that I headed for fellowship and master's project on minimally invasive surgical simulation that was centered on residents. So before starting with my presentation, I'd like to present and thank my research committee, and especially Dr. Jason Harley, who is my supervisor. They're associate professor in the Department of Surgery and director of research at the Steinberg Center for Simulation and Interactive Learning. And thanks to their help, I was able to go forward with this project. I'm gonna do a quick overview of the literature review. As we all know, we have challenges in surgical training. Quality of care is increasingly important as patient safety, yet real-world training opportunities are limited, and surgical expertise is built through practice. Training restriction arise due to increased technical complexity requiring specialized skills, safety concern limiting trainee participation in the OR, diminished working hours, and financial pressures, all conflicting with the time allocated to the residents for training in the OR. And there's a need for a structured robotic surgery training. Robotic-assisted surgeries have increased since FDA approval in 2005. Training, mastering, and assessing robotic skills present unique challenges, also due to high costs of the equipment, the maintenance, and training environment. There's also limited indications for robotic procedures. So far, no standardized nationally recognized robotic surgical curriculum is to be found. We can, however, draw back on lessons from the laparoscopic training, as it has faced similar challenges when it was introduced, and the fundamentals of laparoscopic surgery program was successfully implemented by SAGES, and we can base on this training for the robotic surgery. A key question that does arise, though, is do laparoscopic skills transfer to robotic surgeries? So there's already some literature on this topic, and it has conflicting findings, though. So some studies suggest that experience in laparoscopic simulation does enhance robotic performance, while others find that there is no significant benefit. Some authors demonstrated that skills transfer occurs, but the biggest randomized controlled trial had a large sample size, but only medical students, and they trained on a single task. In contrast, other authors found no advantage of prior laparoscopic experience, but this was when assessing medical students, residents, and faculty performing tasks. And so the samples were very heterogeneous. We found a study that was based on residents only, but the sample size was very little, under 10 residents, and they were doing multiple tasks just once. So with our study, we hope to bridge some of these gaps by having a homogeneous sample consisting exclusively of residents from obstetrics and gynecology, general surgery, and urology. And we will assess the transfer of skills across multiple tasks. And so in our case, 4 tasks, and they will have to reach proficiency in all those tasks. So our research questions. So the main research question is to evaluate whether obstetrics and gynecology, general surgery, and urology residents from both McGill and Université de Montréal, who are randomly assigned to a intervention group that is laparoscopic simulation tasks, followed by a robotic simulation task set, perform better than residents who are allocated to robotic surgical simulation tasks only. I'm going to come back to that later. We also wanted to examine if there's a difference between senior and junior residents. And we also want to see whether residents who are randomly assigned to a laparoscopic simulation task self-report a more favorable experience and outcomes from having a laparoscopic simulation done before the robotic simulated tasks. So as I said, we're going to analyze the transference of skills from laparoscopic to robotic surgery, and it's going to be a multicentric, single-blinded, randomized controlled trial. We're going to enroll all the residents from PGY1 to PGY5 from the University of McGill and Université de Montréal. So we hope that for the participants, it's going to enhance their skills, that they're going to be able to practice in a safe learning environment, that they're going to have broader access to robotic simulation, and they're also going to be able to have personalized feedback at the end of the study. So the research was approved by the ethics board. And the method is going to be the residents who are agreed to participate in the study are first going to be invited for an orientation session where they're going to have to do a baseline task to have baseline score, and they're going to ask to fill a pre-survey. Once they have done the orientation session, they're going to be randomized either in the control group or in the intervention group. If they're randomized in the control group, they're going to have to do a set of robotic tasks, and it's going to be 4 tasks: the C-spike, the puzzle piece, suture, running suture, and knot tying tasks. They're going to be automatically evaluated by the simulator, the SimNow. And they're going to, the proficiency, the cutoff for proficiency is 70 to 80%, depending on the tasks. So once they have reached proficiency, they're going to be able to move on to the next task. For the intervention group, they're going to have to do 2 sets of simulation. They're going to start with the laparoscopic simulations. They're going to do that on the FLS box trainer. It's going to be similar task: peg transfer, circle cutting, suture, and knot tying. They're going to have to auto-evaluate themselves using the traditional FLS scoring sheet. And they're going to have to reach proficiency before moving on to the robotic tasks. And the robotic task is going to be the same as the control group. Once they have done that, all the participants are going to have to do a final robotic task on the actual Da Vinci robot. And the task is going to be video recorded in order to allow 2 blinded experts to evaluate the task using the ORAT score, which is the modified OSAL score for robotic surgery. And they're going to end the study by filling a post-survey. And for the statistical analysis, we're going to do demographics, of course, and we're going to, as I said, compare the scores between the 2 groups, between the intervention group and the control group, and see if the laparoscopy gives a benefit for the mastering of the robotic tasks. So the current state of our project, as I said, we have obtained the approval from the ethics committee. We started participants recruitment, which is still ongoing, and with the participants already recruited, they have started their simulation tasks. So we have started with data collection. Thank you very much for listening to me.
Thank you very much, Nadia, for sharing your plan. That's a wonderful plan. So, can you speculate on what are your expectations?
I am hoping that we're gonna see an improvement on the robotic tasks in the intervention group, in the group that does perform the laparoscopy before.
Okay. And the novelty being, what's the novelty? Can you?
The novelty is gonna be a study based on residents only, and we're trying to avoid having either only medical students, which is not exactly the population that we're trying to study, or to have a very heterogeneous group, as other studies where they included medical students, residents, and fellows and expert surgeons. We're also asking them to do the multiple tasks until they reach proficiency. In many studies, when they had to do multiple tasks, it was just once or a certain number of repetition. They wouldn't look at the proficiency.
Excellent. That's really, I look forward to the
Thank you.
results. Mashid has a question.
Yes, thank you so much, Naja. Great presentation. I'm just wondering what would be the limitations of your work actually? What are the challenges that you might face, like asking questions, or because these actually participants, the residents, they are agreed to actually be enrolled in the study, but what would be the limitations of your study?
The limitation of our study is going to be the recruitment, because it is a demanding study. We all know residents are very busy, so this is going to be one of the limitations, the sample size. We have so far 13 residents who agreed to participate, so we're happy, very happy about that.
Thank you.
You're welcome.
Any other questions?
Just from my side, thank you, Naja. It was a really great presentation. Just, I would wonder if in your group also eager to just combine the artificial intelligence with your project, or you are not eager to just combining, the artificial intelligence, with your studies. This is, my curiosity.
For this study, I think I have other projects in mind that would include AI, but like for this study, I think we will keep it like that and keep AI for other projects. But it is very interesting for sure.
Yeah, thank you. Because for me, it was really interesting. And these days, when you open, any websites, they are talking to just combining the intelligence, artificial intelligence, with this kind of project. But yeah, thank you so much. It was really great.
Thank you. You're welcome.
Yes, thank you very much, everyone. Thank you, Naja. Thank you, Fatma, Muskan, Mohan, Temitop, Pega, for all that wonderful participation. And next week we won't have a seminar. After that, we continue the seminar. So thank you very much, everyone.
Dr. Mwale, can I ask one more question of Nadia? I'm so sorry.
Yeah, sure. Sure, Dylan.
Hi, Nadia.
Hi, Dylan.
I had a question because, in your study, you're looking at the impact of the additional laparoscopic intervention on performance in the robotic simulated task. And I guess I'm wondering about the connection to intraoperative performance that you're hoping to make, I guess. Because I would assume, or perhaps hopefully it's safe to assume that, the premise behind this is that we know that surgical skill correlates with outcomes. And so I'm just wondering, are there the plan for this, or maybe in future studies, to correlate performance on that robotic task with intraoperative performance and eventually with outcomes.
It would be very interesting to be able to do that. Of course, when you study simulation, you always want to know if it's actually transferable in the OR. What we see so far is that the learning curve for robotic surgery for novices is way faster than laparoscopy in robotic surgery. And what previous studies have also shown is that laparoscopy is going to be a benefit for more complex robotic tasks. So there may not be a lot of transfer for simple tasks, but there's going to be some transfer for the more complex task. But it would be very interesting once the study is done to be able to see the actual transference of the skills into the OR and the real world.
That's great. Thank you very much, Dylan.
So before you leave, the next 2 weeks, we don't have any seminar, not just only next week.
Yeah.
The next week. So we see back here in March 18.
Thank you, everyone.
Thanks, everyone, for your questions to Nadia.
Yeah. Thanks.
Thank you.
Thank you so much. Bye.